Do you think we can end TB by 2030? So I love the optimism of Bertie. So there is certainly global political ambition to do so by member states of the United Nations, with ending TB a specific target of the Sustainable Development Goals and the 2023 political declaration on the fight against TB. But does this translate into enough financing, research and innovation, multi-sectoral working and accountability of commitments made? Today we have a lineup of our leaders from the Centre for TB Research who will take us on a journey from discovery to delivery research that we do, and leading into the thoughts of our keynote speaker, Professor Jeremiah Chikaya. There will be an opportunity to ask some questions at the end of each speaker, and more so after our keynote speaker, but I do encourage you to seek us out during the breaks, online and elsewhere, to encourage and support us, engage and challenge us, that we conduct the highest quality, relevant and timely research for the benefit of society. So introducing our first speaker, Dr. Naomi Walker. Thank you.
Hello, it's a pleasure to be here today, and I'd like to thank the organisers for giving me this opportunity. So tuberculosis, or TB, is most often a disease of the lungs caused by Mycobacterium tuberculosis, transmitted by the airborne route. Symptoms typically have an insidious onset, but the damage that tuberculosis causes to the lung can be very extensive, as shown here by the characteristic lesion of TB, the cavity, where the structural matrix of the lung has been degraded and destroyed, and the delicate tissue of the lung required for gas exchange is replaced by nothing but a hole, as you can see on this CT scan. This favours Mycobacterium tuberculosis, allowing it to thrive and spread by being coughed out into the airways. So HIV has taught us we've learned a lot from HIV, particularly highlighting how important immunity is to TB. But in people with advanced HIV, and in whom there is significant immunodeficiency, we don't typically see those characteristic destructive changes in lung TB. The changes that we see with TB are often more subtle. For example, in this patient, a lower lobe pneumonia with some lymphadenopathy. In this context, TB treatment and antiretroviral therapy for HIV are life-saving. But a surprising observation was, with TB treatment and antiretroviral therapy improving immunity, TB lesions would progress and maybe worsen, and as shown in this case, the characteristic cavities, the destructive lesions, can form in a matter of weeks. Here's another example from a person with HIV with advanced disease and a very low CD4 count, where extensive disease of the lung progressed with TB treatment and antiretroviral therapy, with these cavities, these holes forming in the lungs. And this is known as the paradoxical TB immune reconstitution inflammatory syndrome, or TB-IRIS. And a phenomenon like this is also seen with reversal of other forms of immunodeficiency, such as withdrawal of anti-TNF blocking therapies, but also with immune boosting therapies such as PD-1 blockade, given as immune checkpoint inhibitors for cancer. And as I said, we've learned a lot from HIV about the risk of TB, which increases with advancing untreated HIV. We've learned about the importance of CD4 T cells, which are progressively depleted in untreated HIV, and how these cells provide really important support to the innate immune system to try and control TB growth. And in advanced immunodeficiency from HIV, There is much higher degrees of mycobacterial replication seen, as indicated in this figure, and loss of the typical organised immune response to TB that we see in the pathological hallmark with preserved immunity, that of the granuloma. But current understanding suggests that the granuloma may actually help rather than hinder the mycobacteria, allowing it to survive and thrive, albeit at low levels of replication. And work from Professor Mwandumba and others has shown that the alveolar macrophage, the first immune cell in the lungs to see TB and become infected, that Mycobacterium tuberculosis has developed ways of thwarting the antimicrobial activity of TB, which is critical for the disease outcome. So we cannot understate the importance of TB treatment. But researchers from LSTM and MLW have demonstrated that despite successful treatment for TB, up to half of people who are successfully treated for pulmonary TB are left with lasting abnormalities. And this is now known as post-TB lung disease. We can cure the infection, but are we really curing the disease? And we cannot ignore the fact that at the end of TB treatment, many people who are cured may still not feel well or fully recovered. And this slide gives some examples of post-TB lung disease. In A, we have hyperinflated lungs with airway obstruction, which leads to chronic breathlessness. In B, chronically inflamed airways, where there is excessive sputum production, chronic cough, and recurrent exacerbations. And in C, complete destruction of one of the lungs, which can lead to recurrent breathlessness and reduced exercise tolerance. In 2023, we convened the first post-tuberculosis pathogenesis working group at the second International Post-TB Symposium, trying to understand mechanisms of post-TB lung disease. And this group identified 9 key processes, and we've published this recently in AJRCCM. But I just want to highlight 3 key findings. Firstly, the influence of mycobacterial strain or antigen burden is really unclear. It's a chicken and egg scenario. But there is some evidence that drug-resistant forms of TB put people at greater risk of long-term lung disease. Fibrosis, the process of abnormal tissue remodelling, is likely to be important, with high levels of pro-fibrotic mediators at TB diagnosis associated with symptoms post-TB. And studies of genetic polymorphisms have identified matrix metalloproteinase 1, MMP1, as associated with features of post-TB lung disease. And this is really interesting, as the matrix metalloproteinases are host enzymes that collectively can degrade the structural fibres of the lung, structural proteins of the lung, and therefore may be predicted to be involved in this kind of destructive cavity formation in TB. And this is an area that we've studied for some time. And what we now understand is that TB causes a matrix degrading phenotype whereby MMP activity from the host is upregulated, increased, without compensatory increases or compensatory upregulation of the inhibitory processes. And we've shown in studies of people with TB in sputum that MMP1 is significantly increased in people that have cavities and that compared to those that don't. And this has identified novel therapeutic host-directed strategies. Doxycycline, a widely used antibiotic, is also an MMP inhibitor. And so this has now been trialled in a small study in Singapore in TB patients as an adjunctive treatment. And doxycycline addition has been shown to help resolve inflammatory signatures, reduce those pathological MMPs, and reduce lung cavity formation. So it's a really promising strategy that now needs to be tested in larger clinical trials. And we've also shown that you can use elements of the host immune response, such as MMP activity, as biomarkers to try and identify people that either in whom the treatment is failing or in whom there is a greater risk of poor outcomes. And so this figure here shows elevated plasma MMP8 in people that were still sputum culture positive at the end of TB treatment. And these graphs here show a positive association between several MMPs in plasma and Mycobacterium tuberculosis bloodstream infection and risk of death in people living with HIV. There is precedent for host-directed therapies for tuberculosis in other forms of TB, including TB meningitis and in treatment of TB iris, where randomized controlled trials have shown that corticosteroids can improve, the addition of corticosteroids can improve TB treatment outcomes. But there is concern with corticosteroid use about the side effects and some of the negative implications of using those. So we really do need other strategies. And in some very recent work, published just a couple of months ago from the TB sequel group of investigators, we've now got evidence that adjunctive N-acetylcysteine, which works to replenish glutathione levels and reduce tissue oxidative stress, is associated with improved lung function after TB treatment, as shown in these graphs. Again, a really promising example of host-directed therapies to improve outcomes from TB, but we need to again study this in larger trials. So in summary, TB is a disease of too much immunity as much as it is of too little, and not all immunity in TB is protective. We need to consider this when we are testing or trialling therapeutics that or vaccines that boost immune responses, and make sure we are looking out for detrimental as well as beneficial effects. We've gained great insights from studying human TB disease, but we do need appropriate models, and these models really need to reflect the TB disease process as much as it does the consequence of Mycobacterium tuberculosis infection. And as we proceed with therapeutic trials and other studies such as vaccine studies, we should take the opportunity to try and validate immune-mediated biomarkers that can help us better understand the response to TB treatment and identify groups of patients who are at greater risk of poor outcomes so that we can target interventions more appropriately. So I just want to thank our collaborators that have contributed to this work, particularly at RE and University of Cape Town and University of Southampton. I'd like to thank my colleagues at the Centre for TB Research, funders, and of course the participants and patients. Thank you very much.
Thank you, Naomi. I wonder if we go online first, if there's any questions for Naomi. None online. Are there any in the room at all? No. Okay. We'll move on to our next speaker. So I'd like to welcome Dr. Ben Morton. Thank you.
Thank you very much for having me. I'm going to start off by saying I work as part of a very large group, and our group's been doing controlled human infection research for over a decade. We work at the Accelerator building, which is across at LSTM, currently conduct ambulatory controlled human infection models, but with a major investment, we'll soon be able to conduct inpatient models in the very near future, next year, in fact. Right, so what are human challenge models? So this is the deliberate infection of human volunteers. Okay? They have to be done under controlled conditions with a focus on safety both for the participants and for the environment within which they live. The advantage of this approach is that you can monitor infection from the point of exposure until the point of resolution. And this enables detailed measurements of the host and pathogen response. And these techniques have been used widely, and I'll go on to talk about that, to accelerate clinical vaccine, drug, and diagnostic development for a range of pathogens. And the first thing to say, when anyone talks about human challenge, is ethical concerns. And yes, that is absolutely essential, and robust ethical and regulatory frameworks are essential. Okay, just in the development and the thinking of those models, but then subsequently in the conduct of those models. And there's been a huge amount of thinking over the last decade and a half about how these types of studies can be done safely and ethically. And I'm not going to go through this, but this is a panel which was published in Science in 2020, which was the framework development which underpinned conduct of the SARS-CoV-2 models, which were carried out in the UK after and during the pandemic. There has been increasing use of chIMS for a wide variety of pathogens. Again, that list is long. That includes bacterial, viral, parasitic, fungal infections. And these models are well established and becoming increasingly used throughout the infection kind of product development space. I'm going to highlight three kind of key examples. The top example, Vaxchora, is a new licensed oral cholera vaccine. A chIM was used to directly inform licensure of this vaccine, which has been ruled out. So that is, from my understanding, the first time a chIM has been used by regulators to inform licensure of a vaccine. chIMs have been used also within a development process for the typhoid conjugate vaccine program, which has been recently rolled out. And also the malaria vaccines, both RTSS and R21, their development has been accelerated through the use of chIMs. TB. So we all know there's not been a new TB vaccine in over 100 years. There is, though, a lot of excitement about M72. This is the kind of visual abstract. I love a visual abstract from New England Journal, which describes the outcomes from a phase 2 study showing promise in latent TB for this vaccine. And this work has underpinned a decision by Gates and Wellcome to fund a phase 3 trial, which is going to recruit over 20,000 participants across 7 countries, including Malawi, and I understand MLW will be a site, to test this vaccine. It's going to cost $500 million. It's very likely that more than one TB vaccine is going to be required. There are, as you can see, a large number of vaccine candidates in a TB pipeline. It is incredibly unlikely that every one of those is going to receive $500 million to take through to phase 3. And so what we need are tools to select and down-select the most promising candidates to take forward into phase 3 trials. And this is where a TB challenge model could be transformatory. TB challenge is probably the most difficult challenge model to develop. The practicalities are extremely complex. There's myriad reasons why you could not give wild-type TB as a challenge pathogen. I don't think that's possible. But the community's been brought together in a series of workshops, supported by Wellcome, Gates, Ivy, and others, to have discussions within the community to think through how could and how should a TB challenge model be conducted. Our group's been involved in those discussions and tried to help support those discussions. We did a systematic review, which included all the studies, both randomised and non-randomised, where a TB or a mycobacterial challenge has been administered. And there are a number of things to consider. I'm just going to highlight 2 things just to kind of help you more conceptualize some of the issues, 2 major issues. So the first one is, how should we administer the pathogen? So to date, most of these studies have used intradermal challenge of a mycobacterium. Most of them have used BCG as the challenge agent. This is advantageous because you have a localized infection and you can sample that site and you can detect the mycobacterium. The endpoint for a human challenge study is detection and quantification of the pathogen. And so intradermal injection is very useful for that. However, you can very strongly and correctly argue that TB is not transmitted via an intradermal injection, and that may not be representative of a TB infection. And so other groups have gone for lung installation, lung administration of BCG. And there's published examples of direct installation, and there's a nebulized installation of BCG trials which have just completed. Now, this may be very, very useful to understand the host pathogen interaction, but from the studies so far, it's been very hard to reliably recover the BCG, or the mycobacterium, which, as I said, that's an essential primary endpoint. If you've got intervention A, you need to know whether it is impacting on replication of the mycobacterium. And so there's pros and cons to both approaches. The other kind of key issue which I'm just going to highlight is what is the pathogen agent that you should use. BCG is off the shelf. It's been given to over 1 billion people. It's safe. It's M. bovis. It's not MTB. And so you can very strongly argue that a vaccine which protects against M. bovis may not protect against MTB. And so the funders are rightly concerned about using BCG as the pathogen within these models. Some work's been done on GMO BCGs. This doesn't fundamentally change the M. bovis MTB argument, but the GMO alteration has been to incorporate fluorescence so that you can get a better idea of the kinetic of mycobacterial growth, which may be of benefit. But the hope within the community is this GMO MTB strain, which has been funded by Gates and has what the GMO does is it incorporates, dependent on the presence of 2 antibiotics, so trimethoprim and tetracyclines, in order to allow the TB to grow. You remove those antibiotics, the TB dies. And so these have been tested in mice and in non-human primates, have not yet been tested in humans in phase 1s. Pragmatically, to get our program moving, our group has chosen intradermal injection of BCG in order to develop the SOPs that are required, so that hopefully once the GMO MTB strain is made available, that we have all the architecture, experience, skills, SOPs in place, that we can change the engine of the model to the MTB GMO. What have we done? Very briefly, we've done a phase A and a phase B study. There are existing BCG chIMs. In phase A, we've replicated those. What you do here is you inject the BCG and then you take samples, and the existing models do a punch biopsy, which is an invasive, quite unpleasant procedure at day 14 into the lesion to recover the BCG. We've demonstrated that we can replicate that model. In phase B, we've now completed recruitment, and we've gone for longitudinal sampling with minimally invasive biopsy techniques so that we can develop a kinetic of mycobacterial growth, which will be more informative for a model. And we've also extended our sampling techniques to look at compartmental immune responses, which is a skill of our group where we can understand the trafficking between skin, blood and lung as part of our process in order to refine this original model. I'm not going to labour this point, but phase A, we used the punch biopsy. We have been able, with a punch biopsy, to recover BCG, which is reassuring. We've also been able to use these microbiopsy techniques. So this looks and feels like a lancet you would use for a blood sugar. I don't know if anyone's had their blood sugar checked. You can have that done. So it looks like that. And with that technique, we've been able to, again, recover BCG and detect it. And the idea of this is that we can do this longitudinally so that we can measure kinetics as time goes on. What are we going to do with this? So what we want to do is transfer this development, this knowledge, to a TB endemic setting in Malawi. It's vital that vaccines, therapeutics are developed with and for populations who need them most. And so our group has form in doing this already, where we've transferred an established pneumococcal model from Liverpool to Malawi. And this is just an example of a trial that we published last year using the model to evaluate pneumococcal conjugate vaccines in Malawi. So the aim moving forwards is that we're going to have a refined model where we're able to detect microbacterial growth kinetics over time, where we're going to be able to characterize compartmental immune responses. And the idea moving forwards further is that once the feasibility study is being conducted in Malawi, and we're in the advanced stages of having approvals to do that study in Malawi, that we will leverage that experience and those SOPs so that when this MTB GMO strain becomes available, we'll be able to substitute BCG for GMO MTB, and we'll have a model which is fit and ready to evaluate the new vaccines as those come on stream. And that's it. Thank you very much.
Thanks, Ben. Do you have a question, Bertie?
No questions online, but 81 people online, just so you know.
Great. Okay, please do engage with us online and put forward your questions. So, yes, please go ahead.
Am I hearable?
Yes.
Sorry, I just can't hear me, which is probably a good thing. Sorry, my name's Anissa. I'm based in Manchester, emergency physician, and at the HCRI. I was just interested to know, because there are ethical challenges for both inclusion or exclusion of pregnant women in studies like this. Where does that sit with regards to this particular CHIM study in TB?
I haven't either included, I've never included a pregnant woman in a CHIM study to date. In any of the CHIM studies we've been involved in. I think it is a difficult question. I think it's some way away before we consider that. At the moment, it's an automatic exclusion for all of our studies. So I know that's an issue, but safety comes first, and I think that's why that's not been explored yet. Okay.
Thank you. I think we'll just take one more question. I think, Stephen, it was your hand up first. Okay, thank you. Thanks, Ben. That there has been a trial in pregnant women. Is that say that again? Yes, and it's very fresh research, but it is starting to happen. So, okay, all right. Thanks, Ben. Because of time, we'll progress on. So, I'd like to welcome our next speaker, Dr. Tom Wingfield. Thank you, Tom.
Hello, good morning, everybody. Thank you for the opportunity. I'm going to talk to you about ensuring equitable TB diagnosis and access to care. So I think if we're going to talk about the current and the future landscape of TB diagnosis, I think we have to go way, way back to think about how TB diagnosis has evolved. And initially, it was clinical diagnosis mainly. So if we go back to the 1st century AD, this is Soranus of Ephesus, who identified that TB, or phthisis as it was known then, was associated with a cough, with sputum, and that if you put the sputum onto hot coals, it smelt reminiscent of rotting human flesh, as you do. I know many microbiologists want you to sniff Petri dishes, so this is the millennia-old equivalent of that. And then you had Galen in the 2nd century, who identified the 4 cardinal symptoms of TB, so cough with sputum or blood, weight loss, fever, and night sweats. And these are the same 4 symptoms that are used in the WHO 4-symptom screening criteria today. And these are also used in educational materials to support people with TB in communities to see when they might have TB symptoms. This is from wonderful work with Birat Nepal Medical Trust in Nepal, showing some of those symptoms in Mitila art for people to understand and to be able to present to clinics. And still today, much of TB diagnosis still relies on clinical diagnosis. What about microbiological diagnosis? Who's this? Yeah, never nice to have Koch shouted out at you within the first couple of minutes of a talk. But it's Robert Koch, who on the 24th of March, 1882, he went to the Berlin Physiological Society and he said, I have discovered Mycobacterium tuberculosis down the microscope. And this paved the way to other techniques, looking at smears, Ziehl-Nielsen shown here, to actually look and see the TB bacillus down the microscope. Other methods, including this beautiful cording of tuberculosis by the Kinyon method. And then later, from 1905 onwards, actually being able to grow the TB bacillus, in this case on solid culture, Lowenstein-Jensen. But still, many people don't get access to microbiological diagnosis. What about radiological diagnosis? So we have Marie Curie, amongst many things, to thank for this. This is from the First World War. Marie Curie really made mobile X-rays. These were called wonderfully petit curies. And these were for French soldiers and mainly looked at wounds that were incurred during the First World War. And that was translated to tuberculosis. And so in many of the urban centres in the 1950s, there was a push to get out to the urban centres to test people for TB with mobile X-ray. And I think Naomi showed this before as well, but just to show you some features on X-rays. So there's an upper lobe cavity there in the circle and some areas of inflammation and smaller cavities in the middle there. And Liverpool can beat TB, and that's what we're trying to do today. This was from 1959. Every resident of Liverpool got a pamphlet through their door, was asked to present to get X-rays from these mobile X-rays in 1959. So again, the work with communities and the work with the public health faculty is really, really, really important today as much as any day. So we've talked about microbiological diagnosis, clinical diagnosis, radiological diagnosis, and of course we can't go by without talking about guinea pigical diagnosis. So Koch's lymph and Conan Doyle. Hamsters and guinea pigs were initially found by Koch if they were injected with some of the extract from Mycobacterium tuberculosis to in some way be protected from tuberculosis, and that was called tuberculin. And interestingly, as a slight tangent, Arthur Conan Doyle said to Koch, I don't think this is going to be a therapeutic vaccine, but actually you might be able to tell if people have been infected, exposed to TB. Because they noticed that if you injected this in humans, it didn't actually make them better from TB, but you may be able to see whether people, by a mark on the skin, had previously been exposed and had TB sleeping in their body. And this was adapted by Heath, by Montu, and we know all about the Montu tests, to be used as a test for TB infection. And you can see in the picture here in the middle, this is US Army recruits on a mass latent TB infection screening. And from where Prof. Mwandumba works and leads the team in Queen Elizabeth, this is a really strong Montu reaction from a child that I cared for some years ago in Malawi. But just to say that these tests, Montu, Heath, and some other tests will go on, they don't diagnose TB disease, but they can tell if you've been exposed in the past to TB. And that's really important because we're learning more recently that it's not simply this dividing line between TB infection on the left side, lying asleep in your body, and then symptoms of TB, as we talked about, so fever, night sweats, weight loss, cough. That actually there's a group of people in the yellow here that who don't have any symptoms, but if you ask them for a sputum, to produce sputum, if you ask to do a chest x-ray, you may find that they have TB disease, but without having symptoms. So what happened after this discovery from 1882 and then Montu tests in 1907? There was quite a lot of time where actually not a lot happened. In 2008, we had the release of interferon gamma release assays, which are a way of diagnosing TB infection. And then in 2010, we had molecular tests approved for sputum, so using nucleic acid amplification techniques. And these look at the DNA and find the DNA of TB. And so we have examples there that you can do on your sputum, so Expert or TrueNat, and they produce results within a couple of hours, but also are able to look for resistance to some of the main TB medications. There's tests in the urine that you can do, because not everybody can produce a sputum. And so in 2015, the lipoarabinomannan test, the LAM, which is a protein on the outside of the TB bacillus, was brought into play. And more recently, there's been work, just a paper published a week ago, looking at the Expert testing that we do on sputum, but in urines. So with all that, where are we up to then with TB diagnosis? Well, sadly, of the 11 million people with TB globally, only 8 million are diagnosed and reach care. So nearly 3 million never get their diagnosis, they're never notified, and they never reach care. And some of the reasons for that is that there hasn't been rollout to where it's most needed of some of the molecular tests, and we still are suffering to be able to bring people and support people to get to the areas where they can to get tested. So why is that in terms of who might be most vulnerable? Well, you have to think about the care cascade. What is happening for somebody with tuberculosis? So initially, obviously, people are healthy. There are things that make them more susceptible to tuberculosis, be it poverty, undernutrition, diabetes, HIV, overcrowding. But then once they start having symptoms of tuberculosis, they actually then have to be able to seek care. And so there may be a delay when you think of a trade-off between what you have to do in your day-to-day life and going to seek care at a healthcare facility. And then when they do get to healthcare facilities, there may be issues with actually diagnosing TB. People might not send the test, they might not screen in the healthcare facilities. And then further along down the line, although we don't have time today, obviously TB treatment is hard. It takes 6 months if you have drug-sensitive tuberculosis. And you have to be watched usually every day taking your treatment. It's a really big burden, not just to have the illness, but to get treated. And all of that can be associated with other factors that make it hard to get diagnosed. So stigma, depression, catastrophic costs of just getting to healthcare facilities, lost work, out-of-pocket costs. This work by Pedroso Nasengo, who's about to defend his Viva, also shows that this is people with TB in Mozambique. And from the left to the right, these are people who have sought care at a first healthcare provider, a second provider, a third provider, and in some cases have had to visit up to 10 times. And you can see, don't worry too much about the numbers, but these different pathways that people have to go through to get a tuberculosis diagnosis, from pharmacies to public hospitals to healthcare facilities to private clinics. So it's quite a tortuous journey for people to make. And in this case, it led to diagnostic delay of more than 2 months, and that's associated with a real economic impact for people. But not only that, it's associated with more severe TB disease by the time people reach care, and of course, transmission of TB disease whilst people are not on treatment within their households. And so along this pathway from having tuberculosis to actually getting to a treatment centre, to being diagnosed with TB, to being registered for treatment, there's a massive drop-up of people. And so this is where we are really missing people. And the key and vulnerable people who are most likely to miss are actually men who drive the TB epidemic and are still mainly missed compared to women. People who are living in extreme poverty, be it rural or urban, people with HIV, and children. But also there's other specific groups we see in our clinical practice here in the UK: migrants, internally displaced people, indigenous populations, prisoners, homeless, and people who use alcohol or illicit drugs. So where we are right now is that we're still using microscopy a lot on the left-hand side. And a lot of our nucleic acid amplification, like Expert that I told you, is centralized. It's in the larger hospitals. We're only really doing single disease testing for TB, and it's based on sputum predominantly. Most people have to actually get to a healthcare facility to be diagnosed, so get there by passive case finding, presenting themselves. And then there's been a lot of focus on test accuracy. Where do we really want to go? Well, potentially further expansion of some of these rapid molecular TB tests, and that could be decentralized so that they're to places where people really need them. If you're going to be testing somebody's sputum who's presenting with cough, potentially testing for other conditions as well, such as viruses or bacteria, or if you're testing blood, testing for HIV, for hepatitis, for diabetes. There's a lot of work around non-sputum samples, because as I said, not everybody can produce a sputum sample. So, for example, work around mouth swabs, and as I talked about earlier, urine. And trying to bring TB diagnosis closer to where people actually attend and closer to where they live through active case-finding strategies. So, Prof. Luis Cuevas, who is our dear late departed friend and colleague, he started this Start for All project, which is funded by Unitaid, to do just that. We're working across 7 countries, so Brazil, Bangladesh, Cameroon, Malawi, Kenya, Nigeria, and Vietnam, trying to bring diagnosis closer to communities in those places. We're aiming to evaluate the effectiveness, the cost effectiveness, the feasibility, the acceptability to people seeking care of TB test combinations in those settings, but specifically in community and primary healthcare settings where they don't often exist at the present time, to increase the number of people with TB diagnosed and then linked to care, especially those key and vulnerable groups. So we're recruiting about 16,000 people. We're about halfway through that recruitment now. Through passive case finding, presenting to primary healthcare centres, about 7,000 people, and secondary healthcare centres, about 3,000 people. But we're also going out to communities, so to find children in Cameroon and Vietnam, whether they have symptoms or not, nomads in Nigeria, and internally displaced people and urban and rural vulnerable people in Nigeria, Bangladesh, and Vietnam. And we're using a few existing tests, but we're trying to see if we could use them together in combination. So, for example, the expert I talked to you about before, we're using pooling, where you take 4 people's spit samples, but you put it in the same cartridge and run it, and if it is positive, then you test it again individually. And that has been shown in other settings to be very cost-saving. We're using C-reactive protein, which is a marker of inflammation. It's a non-specific marker, but we think that perhaps having had a CRP that's raised might actually give you a better pretest probability with some of the other TB diagnostic tests. Urine LAM that we talked about earlier, but both in HIV-positive people and people who do not have HIV. And X-rays, but with computer-aided detection using AI algorithms and also human reads as comparison. And everybody, all those 16,000 people are getting expert testing in culture. And we will model the effectiveness and cost effectiveness of these different tests in combination. But we're also doing qualitative work to look at the feasibility and acceptability to the people being tested of these different test modalities. So we hope to find the missing millions through some of these innovations. I don't have the time, unfortunately, to talk to you about all the stuff that's going across LSTM, but this is work, for example, using drones to deliver sputum from people in remote communities of Nepal, and also delivery of medicines with the Bharat Nepal Medical Trust. But if you are interested, please do contact any of us from the TB Centre. So in conclusion, 1 in 4 people with TB are missed. So that's nearly 3 million people who don't reach care. We need to use our existing tools in better ways than we are now and integrate with new technologies where necessary. And that would be to overcome the inequitable access to TB care that I've told you about. So we need to find the missing millions to end TB. And we have the tools. It's time to end TB now. Thank you.
Thanks, Tom. No? Okay, please do ask questions online. Go ahead.
Hi, is that working? Hi. Thanks for a really interesting talk. You were talking about the missing millions, and you briefly mentioned that some of the reason why people aren't accessing treatment or testing is, well, because of the socioeconomic impact of some of the treatment. And I noticed you said that there was passive case finding in the Start for All. I just wanted to know a little bit about the community engagement, how you were getting people with the community engagement in terms of some people don't want to be tested because of the impact of treatment.
Yeah, thank you for the question about community engagement. So in Start for All specifically, we are working with civil society organisations, community leaders in all of the areas, sometimes in all the countries we work in, sometimes with existing links and partnerships. For example, the Stop TB Partnership, who are one of the people we work with, already have strong links with certain civil society groups and bodies. But we've also been able to develop new links and new partnerships as we've gone on. And throughout the whole of the project since inception, and now we've been working with those community advisory groups as well to understand better how these tests actually may fit within people's journeys and people's presentations to healthcare, where they may best be deployed. And I see my colleague Vibol in the audience also working through focus group discussions, key informant interviews, in-depth interviews, to really understand the acceptability, not of specific tests per se, but of giving a urine sample. And what do you, how is it to give a urine sample? What do you have at your healthcare facility? Is there privacy? Is it somewhere you'd feel comfortable to give a urine sample, for example? So these are things that we are doing constantly and are a real essential part of what we do. Because if you don't have a test that is feasible and acceptable, then it doesn't matter how effective or cost effective it is.
But what about the aftercare? So if they test positive and they were passively found, just in terms of then treatment and acceptability of treatment?
Yeah, so it's not part, I see Bertie had his hand up as well, but it's not part of what we're doing here, but a lot of the other work that I'm doing outside of this is about psychological, social and economic support once you've been diagnosed with TB, not just for the person with TB, but for the whole household. Tapping into existing things, existing social protection, for example, health insurance, food security packages that there may be available, and working with through peers or people who have survived tuberculosis to help people through their journey with tuberculosis and be able to access care and engage with care through reducing stigma and mitigating depression.
I'm conscious of time, but rather excited we might have a question online, Bertie. So.
There is a question online from Ebuka Ugu in Nigeria. What has been the experience with using blood sample to test for TB in community settings, as this may be quite new for them?
Yeah, so the findings that we're getting so far, we had a meeting, a scientific advisory board meeting and a consortium meeting just a couple of weeks ago now. Most of the blood tests that we're doing are finger prick blood testing, and actually that finger prick is, in most of the settings that we worked in, seen to be relatively acceptable and something that is not uncommonly done. Where we found that there have been issues are where venous blood is drawn, but that is only drawn, so an actual blood sample taken via syringe, but that is only taken in a couple of the sites. So I think in terms of the blood sampling, I think finger prick testing generally acceptable. I think taking blood in other ways has whole heaps of ramifications, both from the health system side, but also from the person presenting.
Okay. Thank you.
Questions pouring in online now, but we'll give you those later,
Good.
Tom.
Keep them coming. So we'll continue our journey now, and I'd like to invite Dr. Rachael Thomson to give our next talk. Thank you.
Thank you. So building on the previous presentations that outlined the drivers of the TB epidemic, I will highlight the gender inequities along the care cascade and how involving those with lived experiences can help reorientate services to be more accessible for all. Studies have shown that the burden of TB across the world is gendered. The recent Global TB report estimated that the TB burden is disproportionately higher among men, and that this difference is seen across all age groups, but especially for adolescents and young men. This slide is from one of our LSTM PhD students, Ebuka Ugu, based at the Zankli Research Centre in Nigeria, and it shows that the gender differences are complex and nuanced. Addressing the gender differences to ensure that TB care services are inclusive requires listening and working with those affected by TB, with their families and health workers. Men face barriers in seeking care around masculinity, high-risk jobs and behaviours such as smoking and alcoholism, while women face powerlessness in health decision-making, high caretaking burden and increased levels of stigma. The World Health Organization has outlined 5 key components for person-centred health services. These are engaging and empowering communities, strengthening governance and accountability, reorienting the model of care, coordinating services within and across sectors, and creating an enabling environment. I'm going to go into each of these sections in the following slides. It's engaging and empowering people and communities. Participatory research methods are needed to actively engage people with lived experience of disease. Experience of the disease and barriers to access are shaped by individual circumstances such as age, gender, economic status, occupation, and where they live. The dialogue needs to be with those living with the disease, with their caregivers, and healthcare workers. In one participatory study in Kenya, one of the health workers remarked how pleased they were to be asked for their opinions about what might work and said, "Nobody had ever asked us before." Another photo voice participant who was a person affected by TB when taking part in the study said he felt empowered and was part of the solution. Crucially, person-centred TB care needs to be embedded in the national TB programmes. And one issue they highlight is that their data is often not disaggregated by gender along the care cascade, and so it can be difficult to know where to target scarce resources. In Nigeria, the National TB, Leprosy and Bilharzia programme have made it a priority to disaggregate by gender the TB data from across all 36 states and at different points of the TB care cascade. This can give them an insight as to where men or women may drop out of care and if there are points along the cascade that could be strengthened so as that more people can reach a cure and improved quality of life. In Uganda and Nigeria, we've been working with people affected to shape and design services so that they might be more appealing for men to seek care while not adversely affecting women seeking care. Examples of these are TB screening in places where men gather, such as football halls, certain workplaces, the use of digital X-ray screening out in the community rather than screening in being health facility based, male-friendly services such as increased opening hours and screening for other conditions such as hypertension, and male-focused TB awareness campaigns. Working with and across sectors is key to ensure that people who do reach TB services get an accurate diagnosis, appropriate treatment, and manage to complex treatment and a positive outcome. Without interventions at all stages of a health system, we see that there are gender differences in treatment success, increased treatment failure for men, increased loss to follow-up, and ultimately increased death rates. There is a need to engage beyond the health sector, such as with the Ministry of Education, to link with schools and university clinics, with male-dominant industries such as mining to support workplace care, and with the Ministry of Gender to have supportive policies. Creating an enabling environment means that all aspects of the health system need to be strengthened and that focusing in just one or two areas will not improve care and not lead to ending TB. Addressing each of the health system building blocks from service delivery, building trust between community and health workers, modelling the disease and improving data reporting systems, strengthening the supply chain and active case finding, alongside cost-effective modelling, and capacity strengthening of stakeholders will lead to increase in quality of services, which ultimately lead to improved health outcomes. The LIGHT Consortium is funded by UK aid and works across 4 countries in Africa, Kenya, Malawi, Nigeria, and Uganda, and is focused on conducting research across the care cascade to ensure that all those who need TB services can access them and reach a favourable outcome from the services. Embedding this research with stakeholders at all levels is crucial to maximise impact. This slide, by the very talented people that are also drawing at the back, shows the types of impact that LIGHT is working to achieve, from conceptual and instrumental impact, enduring connectivity and facilitating networking, capacity strengthening at all levels with a focus on sustainable cultural change and long-term impact. This presentation is on behalf of all the LIGHT partners shown here, and so thank you to all of them.